Thank you very much. I commend these authors as well for an important randomized study, which is hard to be conducted in a challenging disease like this, and looking at pre-operative therapy, particularly important. I eagerly await the final results, and I think it's an important step in what we know about this illness, particularly the role of radiation in this setting for pancreas cancer. There's been mixed data post-operatively, and so I commend the authors for doing it up front and contributing to what we know about what may help these patients with pancreas cancer who might ultimately get surgery.
A question, Dr. Tienhoven, just to put a fine point on the patients who were included in your study. I thought in the abstract, you specifically referred to the patient population as borderline resectable. Is this a patient population that is a little bit further advanced in their disease than the resectable patients that Dr. Conroy mentioned?
Well, usually pancreatic cancer patients are divided in either resectable or borderline resectable, and those two categories are the ones that go for surgery. Part of these patients can't undergo the surgery eventually, but this category of patients we are talking about, yes. Both resectable and borderline resectable, and they were more or less equally divided. So okay. It's 50%, 50%. Okay.
And Andy, a question back to you. Maybe you could comment just briefly on how do you see these two abstracts sort of coming together? Because obviously in Dr. Tienhoven's study, patients did get systemic adjuvant chemotherapy, but not with FOLFIRINOX. And now we have Dr. Conroy's study showing that FOLFIRINOX looks to be a new standard of care. So, what should we be thinking about, for the next patient who walks into the clinic who's got a resectable pancreatic cancer?
Yeah. To me, the main difference gets back to the question you asked, which is about operability or resectability. If you have a patient with a resectable pancreas cancer, my inclination is to, as we saw with Dr. Conroy's study, to have that patient have surgery and then to deliver post-operative treatment, particularly with FOLFIRINOX, as we discussed, if possible. In the setting where there's not resectable disease, but this notion of quote-unquote borderline or possibly resectable, I think that's the main difference. And then we're back in what is going to be necessary before the surgery in order to make operability and other outcomes more beneficial. And to that end, I would say that the role of chemotherapy by itself remains a question preoperatively. This was looking at chemoradiotherapy, and radiation can have downsides. And so my main question as a next step would be the role of chemotherapy without radiation.
Great. So, it's always nuanced, but I think that in a sense the good news is for pancreatic cancer patients who can potentially undergo surgery, the outcomes, are now better than we've ever seen before. So that's a great step forward.